I'll thank you for the invitation to tell something about the Dutch system. It was a little surprised to get the invitation, because I thought, well, as the Netherlands, we are in many ways ahead in general practice, but are we also ahead in data extraction and putting them into the practice? But okay, it's a challenge, I would say. That's why I call this this lecture also a challenge, barriers and challenges. And yesterday I got support on the table at the dinner. I said, well, I have a problem because my message is not so very strong, but they all said uniformly, we will support you. So that's, Okay, let's start. My name is Dijkstra. I work in a general practice. Just to give a short introduction, near Nijmegen, 10 kilometers from the east, in the east of the country. It's a small practice. And the outline of today is how does it work in my practice. So I would like to start from my personal point of view. I will give examples of 3 regional chronic care groups, and I will go to the national development. Normally you start nationally and end in the practice, like in Denmark, but I do it the other way around. So this is my practice. This is the team that we work in. We have 3,350 patients, 1.4 FTE GP, practice nurse and practice assistants present. And we do already for some years, we have our annual reports that we make just for our patients and for ourselves and for sometimes for other people who would like it. And then we have this figures, diabetes care in my practice. These are the known numbers that you can see. Then the question is, how do you get them? Normally, you could say, okay, we have them selected from data extraction, but these data, well, up till 2009, I took them out by hand. Because I made a list of diabetic patients, and then I selected 40 patients, and with those patients I got my data. It's a bit easier now. The last year it became a bit easier, and I will tell you all about it. So regional or national clinical data, we had from even 2000 or before, we already got benchmark feedback from health insurance companies on our prescription, for example. And they were telling us, for example, about statins, how many statins we were prescribing in comparison with other doctors. From 2004, we have the practice accreditation system. And in 2010, the Chronic Diabetes Care Organization. It started already a few years ago, but for my practice it started last year, so at least that gives some development. The practice accreditation, it is too small and it is in Dutch, so it's just to give an example of how we get the feedback there. The same way as you get in other countries, as we have seen this morning. But at least you can see where do you stand in comparison to other practices with process indicators, but also with outcome indicators. And you see here that our smoking, roken is smoking, in our practice has a very low score. So we definitely had to do something about it. Well, just in short about this practice accreditation, because I want to connect the data to what we do with it in the practice, and that is in our case through the practice accreditation. We have a 3-year cycle. We have included organization of care, medical performance, and patient questionnaires. Then we make 3 to 5 improvement plans in a practice. And one improvement plan has to be at the organizational level, one at the patient level, and one at the medical performance level. And the 2 others you can just choose. You get visited by an auditor every year, and you get support by a trained nurse. So that's a system that works already for some years in the Netherlands, and it really helps practices to get a step forward. If you look at the practice accreditation, this is the same slide I showed in Zagreb, but for the people who were not there, it shows that we have about 40–45% at this moment of the practices involved and included in the practice accreditation system in the Netherlands. So that's about 4,000, almost 4,000, it's over 4,000 at this moment that are including here. So they have this system going on every time. Now we have this chronic care system, and I get, because we are dealing, and I will tell you about the organization of that, I get my data in another way. They are distracted from my system by a regional system, a chronic care group that is dealing now with diabetes, later with COPD, later with asthma, later with cardiovascular disease. And they give me feedback on my data. I had a block here, this is just for the privacy of the patients because their names were in it. But normally you see the names of the patients here and you can find back how well you did it. You see the green spot, then you are working according to the guidelines. If there's a red spot, then you're not working according to the guidelines. So that gives at least some information. And that information is also, there are also some other systems that help me in getting the information. This is not from my practice, but this is a system called ProIgia that gives also feedback. It does data extraction in the Netherlands, and it gives it back in a structured way in process indicators and outcome indicators according to the guidelines and the indicators that we make together. Insider is another one. I just talked to Per Sandström. He was this morning here, the inventor of and the owner of Medrave, and talked about the other systems. And I said, well, they are comparable, more or less. No, he said they're not comparable. They are different because mine, Medrave, that's this one, is of course much better. So you see there's some healthy competition between this system, but Medrave is a third system. So I show you now 4 systems in a row in 4 different slides that we have going on in the Netherlands at this moment, being developed, all with the same goal, and that is to give insight in what you do in your practice. And Medrave, I think, is a very nice system. It extracts data from your medical file. You do not have to type twice, and that is a very important figure, I think. Just you get it out of the system, and if you don't get it out of the system, then maybe you don't register well, and then you should register better. That's the message that goes with it. Well, important for this development was the fact that in 2006 we had a reorganization of chronic care in the Netherlands. That had to do with the financing system. There was an integral financing through chain care. Is the term chain care ringing a bell, or you don't know it at all? Well, I will explain what I mean with it. It's of course Dutch into English without any meaning, so I will explain it to you. There were multidisciplinary guidelines made on diabetes, COPD and CVRM, and there were the start of these chronic care groups. And those chronic care groups, they had, well, the reason for that is that diabetes is going so fast. I think this can be put this slide on every country in Europe because it goes up in the same pace in every country. The chronic care, we call it chain care because it has multiple care providers, it has multiple disciplines and multiple care levels, and all those different levels are connected to each other, and that's why it's called a chain. So you don't have the individual professional anymore, you have a professional working together with other professionals, and they have to deal with it together, and they also get one budget to get it done. So this chronic care group gets one budget and has to decide, how do we do our foot care? Is it the podiatrician, or is it the GP, and maybe the podiatrician, or is it the internal specialist? So that's something that has to be reorganized within this within this organization. So just to give it in a diagram, you see here the health insurance is financing a chronic care group, and it has several disciplines, and they have to divide under themselves the care, but also the finances dealing with that care. So if you look at these chronic care groups, you have about 100 now. These chronic care groups have about, on average, 75 GPs per group. You see the distribution over the Netherlands in this diagram, and the big ones are the big groups, and you have very small groups. You have even a chronic care group of only 3 doctors. So it can sometimes become very small in the remote areas, but normally there are about 75 GPs in each region. There's a large diversity, That diversity has to do with the different professional standard, diversity also with the number of programs that they have. Some have only diabetes, some have already 3 or 4 chains that they organize, but also with the quality. Some are very superficial, just organizing the money flow, and others have a very strict quality improvement program. So there's a large diversity in our country. I will talk to you about 3 regional projects. I will not go into them very deeply, but just as for the subject that we have this afternoon. Eindhoven, Oosterhout, Zwolle. There are 3 chronic care groups that are very active. They all make use of the same quality cycle. That means that they collect the data, they report to care group and practices, so as well the whole group, but also the practices. They give benchmarked feedback. All the practices make, based on that benchmark feedback, their own improvement plans. There's a practice visit by a trained professional, and there's reflection on this data and on these improvement plans by an outside person. Practice accreditation, because you see that it's quite similar to what I told you 5 minutes ago, is included in this, so it goes in one flow. And there's a yearly cycle, and that makes that people have the tendency to continue their improvement in the practices. If you look at the Eindhoven example, you see, and the light bar is in 2009 and 2010 is beside it. You see that even if you have already 90% on process indicators, you can still improve. You can wonder how much energy you should put in getting 90 to 95%, but at least you can see that it's moving in all these different practices here on the different levels of care. I mean, HbA1c, cholesterol, HDL, LDL. So it will shift, even if it's good. On COPD, the levels were much lower, but also you see them from the left to the right that they made a large progress in just a few years, just dealing with this cycle, getting the data there, going to the practices, discussing the results, making improvement plans, measuring again. So how did they get in this example the data? In 44% of the practices it was done electronically, extracted electronically by an external party, like ProIgia, Insider or Medrave, the ones I just told you. In 22%, the electronic medical file itself was capable of doing it. In 70%, the medical file gave standard reports that you could use. So they were included in the electronic medical file. 5% still had to do it by hand, and I belong to the last one, the combinations. I can take part from my medical file, and part I have to do by hand, unfortunately. I shift to another example to show you. This is Oosterhout. This is a region also in the southwest of the Netherlands. They have the same system. They also get the extraction. In this case, they get the extraction by real data extraction. You see also that the changes in process and outcome indicators improves in using this strategy. Then the Zwolle project. Zwolle has a bit different type. They're already going on with this project for about 10 years. I think already 12 or 14 years. 1998, oh yeah, that's what it said here. They already started with this project. What the difference between this project and the other two is that they included secondary care from the start, which meant that they looked at who is doing what between primary care and secondary care. The number of patients you see has grown a lot in that time also, and that is the primary care patients. So a lot of secondary care patients shifted to primary care. It meant that primary care had a much higher burden of patients. From 20% it shifted to 11% in secondary care, and insulin treatment in primary care was very much stimulated, because that was previously the reason that patients would go to secondary care, because general practices were not able to start insulin treatment. Now they are, and you see that there is a rise in percentage of patients with insulin treatment in primary care. And that is one of the reasons that it shifted there. So what did it mean in those 10 years? If you look at the HbA1c level, looking over the years, you see a gradual change for the several age groups. It's not very much difference. And the same if you look at the systolic blood pressure, that's on the right version, and there you see a smart change in the, well, they're all gradually going down, but there's a difference in age groups, at least, to be seen here. There's quite some improvement, I must say. If you look at the cholesterol, HDL ratio level, you see the same going down, but you don't see it in the BMI. That stays more or less the same, or even goes a bit up in those years. And you can wonder, is that because BMI is less under control of the doctor and more under control of the patient compared to HbA1c and blood pressure that are merely controlled by prescribing drugs or giving insulin? Well, that's of course, I can't answer it, right? But I think there's an influence of that in this respect. Then the national data collection, and now we come to the struggle part of my talk, and that's why I keep this to the last part, of course. We have a very hard struggle in the Netherlands on getting things on the road. Despite what I told you just before on the several systems that we have that are developing and that are starting up, we have a very hard struggle because all parties that are mentioned here under, Ministry of Health, Inspectorate, insurance companies, health professionals, patient organizations, they have their own agendas. And most non-professional organizations, they say, we want the data to compare it and to use it for payment, we want it for regulation, we want it for having patients making choices, especially the outcome indicators, while the professionals say, well, we're not so in favor of that because we have the impression that especially the outcome indicators do not say anything in comparing different practices. We had this study of José Braspenning from IQ Healthcare, you know, the organization where Richard Kroll started, and they have just did a big analysis saying that if you have less than 350 patients in your group, then comparison, a variety between practices is not very well possible. So if you look at the diabetes patient, I have 145 in my practice. So it would be useless to compare on outcome indicators between those two practices. On process indicators, then the figure is much lower. So it's very much more comparable. The barriers are just what I said, that the political tension is high. That means, political tension means that you don't do anything. The yes but situation, we just discussed it here during lunch, means that you just keep hanging in your resistance. And that's a very big problem, I see. We have no standard procedures. The ICT functionality does not come off. One of the reasons for that is that, for example, the policymakers, like ministry, they advocate that we change a lot and do a lot, but there's no finance at all. So they say, we want you to change, but finance it yourself. Then the professionals go in the yes but attitude, and no things are done. There's limited cooperation between the several parties. There's no economic drive, it's an economic drive to change things. You don't get paid better if you organize it better. Full agendas, of course, is the main barrier always mentioned, but that means that this is very difficult to get this step done. And I'm very sorry that this takes so long in our country, and that we have a very nice general practice system, and we have to keep up the high standards, I think. Well, transparent care, I think it starts with adequate data extraction. And adequate data extraction is really a problem, but what we see also in the systems that we have is that registration of your data correctly is the main barrier that we have, and I wonder in the other countries how you deal with that, but we really have to do some data cleaning before we can really use the data. We saw, for example, in COPD, that's a special group. There are so many people with the diagnosis COPD that should not have this diagnosis. So that's really a big problem. Diabetes mellitus is the same, but a bit less. Then the internal indicators should be used as a feedback and benchmark for the healthcare providers. I think the main reason to do all this is how do you get better in your practice. I think if that's the core message. If we do that, then you can, afterwards you can start comparing with others, and afterwards you can, well, go for public, how do you say it? Well, for public representation and a payment even. Then the external indication, they give information about the quality of care. If you can make this distinction, then you might have a chance that you can have the groups together in this. So what we have now, if you look at the information, you have a sort of selection. If you look at all the treatment information, is the most information that we have. Part of it is the shared treatment information. Part of it is the quality indicators, and then part of that is the public indicators, I would say. And what you see, if you look at the different parties that are involved in all these different situations, is that the one party wants this from the shared treatment information, and another party wants that from the quality indicators, and they don't fix to each other. So that's why people cannot communicate anymore about it. So what we are trying to do now is get all the parties together and say, okay, what we would like is go to core indicators that are comparable through all those 4 situations, and start with it there first. And every party first says, but I want my indicator included as well. But we try to stick to the core indicators, and more or less the indicators that you saw up till now are the core indicators. But we seem to be successful in getting slowly a change in this. Well, we have our first exercise in national data collection done. Of the 100 chronic care groups that we have in the Netherlands, 29 participated in getting their figures done. That is for a population of about more than 4 million people. And the mean number of patients per care group were 140,000. Then you can put them all on one line, and you see that the HbA1 checked during the last year is quite high, with just a few practices or pure care groups that are lower. The HbA1c under 7 is quite comparable if you look at these groups. Same is for the blood pressure management, and the systolic blood pressure under 140. See that about 52–53%, that's the average, or the mean, I must say, is just over 50%. So the eye control done, that has more diversity. You see there are more differences between practices. There's even one or care groups, I'm sorry. One care group even has it below 30%. Well, I think there's some reason for attention to whether they register in the right way or they don't do the exams. That is always the question then. So if you overlook this all, then you see that the registration and extraction problems, they influence the outcomes largely. That's one of my points. I think if we want to use data extraction to deal with an improvement, we must be very sure that we have the right data and the right registration. There must be uniformity on in or exclusion criteria. That is, the guidelines state quite clearly when you conclude that someone has a COPD, but in the registration you see different ways. So we must be very clear on that. And also, it was said also this morning, chronic care groups just need a few years. You don't get this in 1 year. You need about 3, 4, 5 years before you get this well organized. So that's one of the lessons that we have learned. Case mix differences, they are really a challenge. So how can you compare different groups, and how do you include case mix differences? That's not easy to have a right answer. There are some groups that say you should never do case mix correction because just give the data and this is for the interpretation of the groups themselves. Others say at least age and sex should be taken into account, so to compensate for that. But there's quite a discussion. And how to make an honest benchmark. I think that's not very easy. Same accounts for what is good. We always tend to go to the average or to the mean. If you're very high, then probably there's something wrong with you. If you're very low, then probably there's something wrong with you. But the only thing that we can say is that you deviate from the mean. And what does it mean for you? I think that's an important lesson. And my last one, I think feedback information is especially important for the internal quality of the practices, and that should be the core message, I think, for all of us. What we do now with this core sets that I was just discussing, this pyramid that I showed you, we are trying to make them for the several diseases similar, because you always have some of the indicators that overlap. At least they should not be contradictory or be different. So we start with general parameters, and every disease will have its own indicators that are specific for that disease. So what we're in our idealistic plan, we think that you have these quality measures that should come from the left and the right, from the practices and care groups, by data extraction, which have to be authorized, which have to be correct, which have to be checked on good registration, etc. I think you could take it together with figures on costs, with figures on patient satisfaction, that is patient data. Then you will have aggregated authorized data, but also that might be the right source to have material for scientific research. If you have it in this way, well organized, then I think this research can be one of the parts of this process. Okay, that's what I would like to tell you. Thank you very much for your attention.